Thank you, Dr. Gopal Raju, Madhu, and Andhra Pradesh Ophthalmic Society for this opportunity to present in this forum. Yeah, so I shall be presenting on the recent advances in ocular oncology, uh, what we are doing new in the last few years. So I have divided my talk into four parts: eyelid, ocular surface, orbit, and intraocular malignancy. To begin with eyelid, I will be taking you through a series of cases um, and sharing the knowledge learned. So this particular girl, 6-year-old girl, the right eye, she presented to us with ocular surface squamous neoplasia with orbital extension. You can see that we had to enucleate the eye, and that's a customized ocular prosthesis that the girl is wearing. But what I want to focus on is that the child has a xeroderma pigmentosum. So there were multiple squamous cell carcinoma which used to pop up from different areas of her skin, and you can see that skin grafting, excision biopsy skin grafting has been done, and there are new lesions coming up from the edges of the skin graft. So for this patient, we resorted to the use of imiquimod cream once daily for 2 months, and the lesions, the superficial lesions, were taken care of. So topical imiquimod is freely available, cheap, and is a good option for multiple superficial squamous cell carcinoma or basal cell carcinoma in such patients with xeroderma pigmentosum. So, apart from imiquimod, 5-fluorouracil, photodynamic therapy, targeted therapy with vismodegib or sonidegib has been reported in literature, but in developing country like ours, this hedgehog pathway inhibitors are not available, and the use is also restricted because of the expense and the fact that there is recurrence on stoppage of this medication. However, the tumor free span has been reported to be around 80 to 90% for a period of 3 months. Moving on to neoadjuvant chemotherapy for eyelid tumors. Earlier, for sebaceous gland carcinoma with an orbital extension like this, the only available treatment in our armamentarium was orbital exenteration. However, now we have a fairly established protocol for chemotherapy consisting of cisplatin and 5-fluorouracils. We chemo reduce the tumor, and once the size is reduced, we do a eyelid sparing procedure reconstruction, like you can see in this particular patient. Eyelid sparing procedure was performed in this case of an extensive sebaceous gland carcinoma. MAP biopsy for sebaceous gland carcinoma. As you all know, pagetoid spread in sebaceous gland carcinoma is reported in literature to the extent of 16 to 80%. Earlier, the training was that whenever we used to see clinical signs of MAP biopsy like diffuse conjunctival congestion or a diffuse thickening of eyelid, loss of meibomian gland architecture, loss of eyelashes or a surface telangiectasia, we used to go ahead and do a MAP biopsy. But recent literature from our center shows that we will miss 10% of cases of pagetoid spread if we just go by clinical diagnosis. So it is best that we perform MAP biopsy in all patients of sebaceous gland carcinoma and then go ahead with a protocol based management for eyelid tumor. So we need to look in, just excision biopsy for eyelid tumors doesn't suffice. We need to look into the histopathology report and into the risk factors: perineural, intraneural, vascular emboli, and if any of these are there, an EBRT needs to be considered. Fixed frozen mismatch is also a possibility for these patients, and if there is a margin positivity after reconstruction, and if it is lamellar, consider cryotherapy. If it is full thickness, consider radiation. So MAP biopsy positivity, if it is localized, topical mitomycin C and cryotherapy are options. If it is diffuse, orbital exenteration needs to be considered. All patients with eyelid tumors, regional lymph node assessment is a must, and if there is a metastasis, radical node dissection and radiotherapy needs to be clubbed to the treatment. Moving on to ocular surface tumors, so there has been a paradigm shift in the management of Ocular surface squamous neoplasia. Earlier, the no-touch surgical excision with cryotherapy was the standard of care, but now again there is a lot of evidence that topical chemo and immunotherapy should be the first line of treatment. As we all know, ocular surface squamous neoplasia is a clinical diagnosis where we see a limbal nodule with corneal involvement and intrinsic vascularity with the feeder vessels and surface keratin, and on ASOCT the diagnosis is confirmed with the presence of the thickened hyperreflective epithelium with an abrupt transition. The drugs which are available are mitomycin C, 5-fluorouracil, interferon alpha 2b. Most commonly used are 5-fluorouracil and interferon alpha 2b. And so we immunoreduce, immunoprevent, and do immunomodulation. I will come to each of them. To reduce the tumor size for extensive OSSs, definitely topical immunotherapy is the drug of choice, like this diffuse placoid tumor or more than 6 clock hours of limbal involvement, like you can see here. So immunotherapy works wonders for this. For these type of patients, you can see this is pre and this is post. The entire ocular surface is free of the disease. It can be used for immunotherapy in cases of corneal OSSN, where otherwise alcohol keratoepitheliectomy, which we used to do earlier, used to result in corneal scars. For small tumors, recurrent tumors, and post-PK patients, again, this is the drug of choice. So immunoprevention, whenever in the histopathology you see a margin positivity, consider 3 cycles of immunotherapy in the post-op period. And it is very important to understand when not to consider topical therapy when the diagnosis is in doubt. Like this particular patient was diagnosed as OSSN, but it is not a case of OSSN, it's a case of eyelid sebaceous gland carcinoma with a pagetoid spread. So whenever in doubt, go ahead, perform an incision biopsy, establish your diagnosis, and then go ahead with topical immuno or chemotherapy. So whenever the depth is in doubt, like this particular patient with scleral fixity, you can see on the UBM the anterior scleral layers are involved. Don't consider immunotherapy. Go ahead and do a surgical excision with a lamellar sclerectomy. So whenever there are signs of scleral invasion or intraocular extension, like deep corneal invasion, AC cells, secondary glaucoma, corneal perforation, topical immuno or chemotherapy is not possible. You need to go ahead and perform surgery. T3 stage, that means involving the adjacent structures, like in this particular patient, you can see caruncular involvement, punctal involvement, eyelid involvement. Then again, topical therapy is not of choice. Whenever the patient compliance is doubtful, you can't consider topical immunotherapy, and routinely it shouldn't be given. It should only be given if there is a margin positivity post-surgery. Something again new, a new kid on the block is the laser photocoagulation for benign conjunctival tumors. We are using laser photocoagulation, like in our center we use yellow laser, the same laser that our retina colleagues are using for photocoagulation. And this is how the visual changes appear: first graying, cavitation, blackening, then we can remove with bud. And you can see for such large tumors as well, of course these are benign tumors, so you can see it has nicely resolved without any tissue dragging, which is the case with surgical excision. Plaque brachytherapy for conjunctival tumors. This patient of leiomyosarcoma, post-excision plaque brachytherapy is a must to reduce the chances of recurrence. Similarly for OSSN, whenever there is a base positivity, like in this particular patient in the post-op period, you will have to consider, there was a base positivity here on the histopathology, you will have to consider giving the patient plaque brachytherapy. We have recently started in our center. It requires a lot of licensing, so we have done that and have started plaque brachytherapy. Moving on to orbit. So 12-year-old child came to us with the left eye bulging out in the past 3 days, and there was a history of preceding upper respiratory tract infection. So this is a typical case of venolymphatic malformation. Further on CT scan, you can see ill-defined multiple cystic masses, which is transcompartmental with multiple air fluid levels. So this is nothing but a venolymphatic malformation with bleed, what we earlier used to call as a chocolate cyst. So we did a blood aspiration with bleomycin sclerotherapy, and this is how she was in the post-op period. So sudden intraorbital hemorrhage in a child, think of venolymphatic malformation and treat with bleomycin sclerotherapy. Again, for vascular orbital tumors, like this particular lady, 57-year-old, came to us with this large palpable inferior orbital tumor, which was causing a lot of indentation on the globe, choroidal folds, tortuous vessels. In the MRI, look at these flow voids or the vascularity of the tumor which is there. And we reviewed the previous records and found out that the patient has already undergone an orbitotomy at a different center, and there was torrential bleeding on table which required the surgeon to use all possible forms of hemostasis. However, the surgery had to be abandoned because the bleeding could not be stopped, and the incision biopsy showed this to be a solitary fibrous tumor. So we have a hypervascular solitary fibrous tumor causing mass effect. There is an attempted surgical excision, which we know from our knowledge of literature that is a known risk factor for malignant transformation. So what do we do now? So we did, the options were radiotherapy and embolization. We did a embolization because it's a targeted form of therapy, saves time and allows immediate surgery. So with along with the help of our interventional radiologist friend, we embolized this feeder vessel, and you can see the vascularity grossly coming down, and we could safely do a surgery at 1 week after 1 week of the embolization procedure, and this is at 5 years follow-up. So, in collaboration with interventional radiologists, preoperative embolization is a very safe procedure for hypervascular orbital tumors like solitary fibrous tumor or alveolar soft part sarcomas. Again, I want to show this particular patient intraconal run-of-the-mill orbital mass. We did a cryo extraction on day 1. The vision was NPL. And so we are very prompt in publishing our complications. So we published this particular patient, and you can see there's an ophthalmic artery occlusion with a cherry red spot there. So keeping this in mind, we need to understand, like this lady, 39-year-old, best corrected visual acuity 20/20 in both eyes. She just came to us because there was a visual blur in the left eye. And what do we see here? In the MRI, we see a highly enhancing small mass abutting on the optic disc, causing this disc edema. This is nothing but a cavernous hemangioma. So we considered IMRT, stereotactic radiosurgery is the term we use nowadays. And proton beam should have been the best possible treatment, but the availability is very less and it's very expensive. So we went ahead with a stereotactic radiotherapy. So for stereotactic radiotherapy, earlier it used to be an invasive BRW frame to ensure that the eye doesn't move. Then we moved on to non-invasive GTC frame, but now things are very easy. We just use a brain aquaplast onboard imaging, and you can precisely target the radiation to the tumor, and that's why it's known as a stereotactic radiosurgery. So that's what we did for our patient, and this is how post IMRT you can see the visual field defect has come down. The optic disc edema is also gone. So stereotactic radiosurgery is a good option for apical tumors, one-eyed patients, recurrent tumors, optic nerve sheath meningiomas, and a good rapport with your radio-oncologist helps. The last part of my presentation, intraocular tumor. So intraarterial chemotherapy, this was again a paradigm shift from intravenous chemotherapy, and globally this is the standard of care, but not for us in India, because each session cost us around 2 lakhs, and you need people who have expertise in the procedure. So though it's an established technique, it's expensive, does not take care of the systemic micrometastasis, and the complications are devastating, like ophthalmic artery occlusion. So the technical expertise is of utmost importance. So this is the protocol we use at our center, triple drug regimen. This was the first intraarterial chemotherapy we did in the state of Andhra Pradesh. It was a collaboration between interventional radiologist, pediatric oncologist, and so basically what we do here is we go through the femoral artery, and microcatheter is introduced, which goes into the common carotid artery, from there into the internal carotid artery, and we stop at the ostium of the ophthalmic artery. From there, the chemotherapeutic drugs are injected slowly. So it's a triple drug regimen. If you use more drugs, the number of sessions will come down. As I said, it's a very costly procedure. So the drugs are injected very slowly, and they go into the ophthalmic artery circulation and effectively reduce the tumor. So this is again a patient post primary intraarterial chemotherapy. You can see of retinoblastoma, which has completely resolved. Intravitreal chemotherapy is again absolutely a game changer. Earlier in our residency days, the traditional teaching has been you can't go into an eye with retinoblastoma. There are chances of spread of tumor cells, but with the Francis Munier group coming up with this particular type of chemotherapy, and it's absolutely, as I said, it's a game changer for patients with vitreous seeding in retinoblastoma. And the site is being marked. We are injecting topotecan slowly, 30 microgram in a 0.15 ml, and withdrawing the needle should be through the cryo ice, and then you need to do a triple freeze thaw cryotherapy at the site of injection just to ensure that there's no tumor cells left behind. And this is followed by jiggling of the globe to ensure that the drug is distributed equally in the vitreous cavity. So safety enhanced intravitreal chemotherapy is what we do. As I said, choosing a safe site where there are least vitreous seeds, thin gauge needle, 30 gauge ideally, exit through the cryo ice, and then a triple freeze thaw cryotherapy. Death by water means just flushing with distilled water, so that even if there are tumor cells there, they are washed away. You can also raise a bleb of subconjunctival topotecan. So earlier we used to use intravitreal melphalan, but there were a lot of side effects, the most important being these pigmentary retinopathy. So we have now completely moved to intravitreal topotecan with no retinal toxicity, with enhanced efficacy. So again, this is one such patient where we used a bilateral patient where we were able to salvage the left eye only because of this modality, intravitreal chemotherapy. Intracameral chemotherapy is again something very new which has come up, and for treating aqueous seeding in retinoblastoma, but the choice of cases is very important. This is one such case where we effectively, with the help of intracameral topotecan and intravitreal topotecan, a combination, we were able to achieve tumor remission. The last patient, this child with retinoblastoma, we were continuously facing a difficulty where the PMMA implant was going and settling into the inferotemporal quadrant, and twice the implant exchange was done, but as the Tennant's capsule was not there and the fibrous septa was missing in the inferotemporal quadrant, every time it was going and settling in the inferotemporal quadrant. So the options in such patients are implant removal with dermis fat graft, but we did something very new. That is, we did created and fabricated a customized orbital 3D implant which was fitting, as you can see in the CT scan, it is just fitting in the inferotemporal quadrant. This was made with the help of the DICOM images of the CT scan, from where a 3D orbit was created, and in that orbit the 3D implant was fabricated. So these patient-specific implants is again the way forward for such complex cases, and we were able to place a customized ocular prosthesis successfully. Thus, to conclude, eyelid, we talked about targeted therapy, neoadjuvant chemotherapy for sebaceous gland carcinoma, map biopsy, having a strict post-operative protocol for ocular surface, understanding noduloulcerative OSSN, the laser topical immunotherapy, and the indications where we can't use them, laser photocoagulation for benign lesions, plaque brachytherapy, for orbit, gliomycin for venolymphatic malformation, performing a preoperative embolization for hypervascular orbital tumors, radiotherapy for intraconal apical tumors, intraocular, intraarterial chemotherapy, intravitreal, intracameral chemotherapy for retinoblastoma, and customizing for each patient for the best possible outcome. 3D printing of orbital implant is the way forward. Thank you everyone for a patient listening.
That was an excellent presentation, Anasua. Thank you. Any questions? Okay. Thank you all. I thank all the panelists today. Thank you. I'll hand over the session to the next one.